Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer at the European Hematology Association, EHA. Welcome to this podcast on the successes and challenges of generating allogeneic CAR T cells from iPSC cells. Today, I have the pleasure to be joined by Professor Maria Themeli. Welcome.
Thank you. Thank you for inviting me.
Could you please start by introducing yourself to the audience?
Yes, my name is Maria Themeli, and I am assistant professor in the Department of Hematology in Amsterdam University Medical Centers. I'm group leader there, and my focus of research is the design of new chimeric antigen receptors and new methods for improving the safety and efficacy of CAR T cells and accessibility. So a very big part of my work is based on generating CAR T cells from alternative sources such as induced pluripotent stem cells.
So you do more research than seeing patients, or do you do both?
Yes, I do more research, although my background is medical. So I have studied medicine originally, but I never practiced. I switched immediately to science and research, yes.
So in this episode, we'll explore the latest progress in making off-the-shelf CAR T cells a clinical reality. To start things off, could you please explain what are off-the-shelf CAR T cells and how could they solve the challenges of existing autologous therapies?
To begin with, when we say the off-the-shelf, this is this expression, we mean that we would like to make CAR T cells, this living drug, the same as other drugs that are based on like antibiotics or biologicals that you can just prescribe and take from the pharmacy. So that's what we mean, that they are available immediately upon prescription from the doctor. This is not the case right now for CAR T cells. The CAR T cells need to be manufactured from the cells that are isolated from the patients. This means that there is a whole process that needs to be initiated. After taking the cells from the patient, the cells go to a manufacturing facility. There they go through a specific process and they are released to return and be infused to the patient. So this is a process that takes time. We strive to make this as short as possible, but then there are still patients that cannot receive the product that has been made for them because the disease has progressed so fast that there was no time. So it took long for the manufacturing. Other reasons are that the cells that are coming from a patient, of course, they're not not the same for every patient. So every product is different because it is affected by the previous therapies that the patient has received, the type of disease that the patient has, or the tumor load at the time of leukapheresis. All these can affect the quality of the CAR T cell product and subsequently the clinical response. So we would like to have a uniform product like with biologicals that you would predict more or less what would be its function, and it would be more uniform across the patients.
So which types of cells are being explored as potential cells for allogeneic CAR T therapy?
There are several clinical trials that have been initiated using allogeneic healthy donors. The idea behind this is that when you have a younger and healthy T cell, it would have much more functional fitness. And indeed, this is what we see also in the lab in vitro. The problem starts when you have to apply this allogeneic T cell therapy because these cells need to be changed. We have to edit them. Otherwise, they will be rejected from the recipient or you have to have histocompatibility. Otherwise, the cells will be rejected. So we are trying to generate modifications in the cells so that they are not going to be rejected. Another thing that we need to take care of is that the cells are not going to attack the recipient, what we call graft versus host reaction. So they need to be edited so that they will not recognize the host, the recipient, as foreign. So all this editing process is an extra step in the manufacturing, and it's not perfect. The allogeneic CAR T-cell products, after manufacturing, they still don't have the same functionality as autologous. Just because we cannot really perfectionize with all this editing the immunotherapeutic properties that we need to have. So they still have limited persistence within the patient's circulation, because even though we do some editing, they will still be rejected. So this is the areas of improvement. And this is where the iPSC-derived cells as an alternative source comes to potentially solve some of this.
Because so there are allogeneic cells that could come from a donor.
Yes.
That is compatible. But that's very hard to find. Of
Exactly.
course, somebody that is compatible.
Exactly.
So you are trying to make cells that would be some kind of universal, so compatible with many people,
Exactly.
if not everybody, by removing the reaction to HLA.
Exactly. So we have to remove the T-cell receptor from the cells so that the T-cells will not recognize the recipient, and we will not have graft versus host reactions. And we have to remove the expression of HLA molecules from the cells so that they are not going to be rejected from the immune system of the recipient. So these things have to both happen. Until now, clinical trials with allogeneic CAR T cells, they edit the T cell receptor because this is the most important. But still, the editing that aims into to prevent rejection is not optimal. So these patients, we try to lymphodeplete, so reduce their immune system so that we can expand the lifespan of these allogeneic cells within the system of the patient. But that's not the optimal way. They will still be rejected, so that their persistence is shorter than the autologous. And we know CAR T cells, and we know that persistence is very important for the clinical efficacy. So
you have been working for a very long time using induced pluripotent stem cells, so iPSC cells. Yeah. Why use iPS cells?
So first of all, induced pluripotent stem cells, they can be cultured unlimitedly. So it's an unlimited source. So this is one of the benefits. So we will not need to have donors or search for donors all the time. A second is that iPSCs can be, because they can be cultured unlimitedly, you can generate and introduce any genetic modification. And with every modification, you generate clonal populations that have a specific the specific change, and you can test them for any genotoxicity or and this can happen once. So it's not like you do the editing and the engineering in a bulk population of patient cells, and then you have to test this bulk population. And every time that we are doing this new production, every time it needs to be tested. So theoretically in iPSCs, you do it once, and you can do multiple multiple engineering rounds, which is not possible in a primary T cell setting. So this is the second benefit of iPSCs. And when we're moving towards improving CAR T cell products and talking about multiple changes, multi-engineering, multiple receptors, mutations, new transcription factors, or cytokines that can be secreted, and going into modification of the tumor microenvironment that will be needed in solid tumors so that CAR T cells can be effective. This multi-engineering is is limited in the primary CAR T cell setting, primary T cell setting, patient-derived or healthy donor-derived. So this is a third benefit, advantage of having iPSCs as a source.
But so to make iPSCs, you need to first also have a donor cell.
Yeah.
You have to turn it into an iPSC cell.
Yeah.
And then you have to differentiate it again as a T cell. And you have to put a CAR at some point too also. Do you work through all these steps to get a final cell that really could go into a patient? It's a long process.
It is a long process. The first step is to find a donor, and that would be theoretically is one donor, and we have to find. We're still investigating what is the best donor, but not only the best donor, but the best donor cell. Is it better to have a hematopoietic cell as a initial parental cell, or any other type of cell could do the same job as efficiently? We tend to think, and our experimental data show that if we want to go to T cells, it's probably better to have as an initial cell a hematopoietic cell, or better a T cell. So that's the first. Then selection of a donor, the informed consent of the donor has to comply, and the donor has to be to agree that his or her cells will be used for therapeutic purposes, etc. So that is also in the ethical point of view important. And then you have to make this iPSC line from these cells using GMP grade materials under GMP conditions, and generate a GMP grade line. That's also, it costs a lot, of course. And but when you have this GMP grade line, then this line will be modified, can be modified for with different CARs. You can put any other modifications that are needed.
It's like removing the HLA or...
Exactly. And then you the purpose is to make this, what we call the master cell banks. So master cell banks of these iPSCs, the modified iPSCs. And when there are differentiation protocols, we and others are working on making these protocols for differentiation more efficient, scalable, expandable, that it's not only a protocol that you can use in a specific center, but it can be used easily transferable. So this is what we're working on in bioreactors. This process can lead to the production of multiple doses of CAR T cells. At the moment, for example, at least at research level, we are able from one iPSC to generate thousands of T cells. So imagine if we go higher in scale, right? Then from a few iPSCs that we can make a lot of CAR T cell doses. So that's the idea of, in the end, reducing the cost. So depreciating actually the cost of generating all these cell lines by the fact that they will be available for more patients.
Yes, because you produce them once.
Exactly.
For many patients.
Yeah.
Mm-hmm. So which steps are more challenging at the moment?
Yeah, there are many things that still are not optimal because first clinical trial with CAR T cells from iPSCs has been done, and it is very important that it has been done because it has shown that this type of cells are safe. They have function. They are functional. They had anti-tumor responses, but there are many steps that we need to do in order to improve the iPS-derived T cells, and that's because our in vitro differentiation manufacturing processes are still not optimal to get us to the same developmental maturity that is needed in order to have the full memory and proliferative function of T cells. There are still now there are efforts to generate both lineages, sublineages of T cells, CD4 and CD8, but also Tregs for let's say if we go to autoimmune diseases. So until now, the generation of CD4 cells was not possible with the protocols that we were applying. Nowadays, there are new studies showing that it is possible to generate CD4 cells. We still need to find out what is the functionality of these cells, but it is critical that we make mature cells with memory properties, and that we have both CD4 and CD8s. We know from CAR T cell studies that those two subpopulations, they need each other, right? So having CD4s to help the CD8s is important. So these are specific aims that we have in order to improve iPS-derived CAR T cells. And then is the manufacturing, as I said, we have to generate protocols that are scalable. Mm-hmm. We have to have feeder-free, xeno-free methods that can be applied at the GMP grade.
Yeah. So that these products can be applied to a human.
Yeah, being, exactly. Because, Mm-hmm. There is a clinical trial, and at the moment it's using feeder cells still. This is possible but you have to. These feeder cells need to be GMP approved, so they have to become GMP grade. That's a step that is It takes time, and it is difficult, and it's not transferable, right? Mm-hmm. So it's not that in every place a GMP feeder line, which is from murine origin, right? So, mm-hmm. So it's not easy to be done. If there are protocols that are free from the use of feeders and can be, dependent on just recombinant proteins that we can use, or media, mm-hmm. and chemicals, mm-hmm. that would make it much easier to apply.
So also there could be a risk of contaminated, undifferentiated iPS cells, no? How do you minimize this risk?
So in the T cell differentiation process, that risk is very, very low, because the steps that this process takes, there are many intermediate steps. So in order to go from iPSC to a T cell, first you need to make hematopoietic progenitors, CD34 positive hematopoietic progenitors. And at this stage, we can select those cells and purify them. So there's a first purification step, mm-hmm. and after that step, those cells are being put into the T-cell differentiation part of the protocol, and most of the times during this process, the cells either become the T-cells that we want or they die. We have never seen any other type of cell in this product. But these things, if you go into a GMP clinical grade manufacturing, the product needs to be, of course, characterized and eliminate any trace of previous non-differentiated cell.
So you mentioned there has been one clinical trial with iPS cells. Only one? Is
with T cells. Fate Therapeutics has done also clinical trials with iPSC-derived NK cells.
Okay.
And there's one study that was with iPSC-derived T cells. And right now there is another open study with the same product against autoimmune diseases. So this is the second, let's say, trial with iPSC-derived cells, T cells.
And so the results are already available?
Of the first,
yes.
There was some reports from the.
How close are these kind of cells then for being used for clinical purposes?
As I said, the results in terms of efficacy
is good.
It was not so good as the autologous product, and we know that for the T cells, iPSC-derived CAR T cells, we still need. They still need to be improved for reaching the same efficacy as primary CAR T cells.
So, do you think that at some point you will have these universal CAR T cells that will replace the autologous, or will they be a complement?
This is also the same question for also in vivo CAR T cells. So in vivo CAR T cells and off-the-shelf CAR T cells are the two strategies to overcome the accessibility issues for CAR T cells and also the fast need. So if they will take over. For the moment, I don't think so. For the moment, I think that there is space for the cases where you have really rapid progression. So this is the time where you need a fast to have access to a CAR T cell product. When we find that we will have a superior efficacy by engineering, because multi-engineering probably will give us the opportunity to have a superior efficacy, I hope, in the future. When we reach that place, and for specific tumor contexts, maybe there we would think that they are preferable to have this iPSC-derived products. But that only the future will show, what would be the advances in the field.
You need comparable efficacy at least,
exactly.
And lower cost.
Exactly, yeah.
Yes. But that's what you're aiming for in any case.
Yes.
So we are at the CAR T meeting in Strasbourg in 2025. What new developments have got your attention specifically?
Yeah, we had today a very nice session, which was dedicated to the very innovations in CAR T cell therapy involving genome editing, I think, and in vivo T cell generation, CAR T cell generation. I think this is a rapidly developing field, and which is sparkled by the need for access and reduced cost. I think this is the major driving force at this moment. And we saw very nice presentations of how we can use genome editing to identify ways to improve CAR T cell function, but also to generate in vivo CAR T cells. So I found, at least today, I found this session very inspiring. But I also find very inspiring the fact that in our meeting we will have, I see a lot of new clinical trials initiated also in Europe, and I think this is very encouraging that we are, starting to try and in first-in-human trials, new next-generation CAR T cell products. And I think we have to find a way that we will increase that, the opportunity to try and have more clinical trials, because there are many researchers that are reporting improvements in CAR T cell engineering, and this have difficulty to find their way towards a clinical translation.
Yes, and also, so CAR T cell therapy started in hematological malignancies, but now it has spread to other kinds of indications beyond oncology. So I guess this is also the reason why you have so many clinical trials going on. It's really exploding as a technique to treat different diseases.
Yes. Mm-hmm. With this expansion of CAR T cell therapy is increasing also the need, right, for manufacturing. So there is one more reason of the self sources can serve here, because the demand for CAR T cell therapy will be increasing the next years. So, and I don't know if centralized manufacturing or this type of manufacturing processes from autologous-based products would be sufficient for such a high demand.
Thank you very much, Professor Maria Themeli, for this insightful conversation and for sharing your valuable insights with us. Thank you to all of you for listening, and stay tuned for our next episodes.